This week on the BackTable Podcast.
Even if the patient is really unhappy, the reality is you did the safe thing and you're avoiding some of this. I think we're going to find as we're measuring these pressures, that does really correlate whenever we go in without a sheath, whenever we have very narrowed ureters. I think we're going to see that pressure goes up. Now, whether that translates into more pain, bad outcomes for the patient in terms of infection, I don't know yet, but it does seem like those at least correlate.
Hello everyone, and welcome back to BackTable Urology Podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, at backtable.com. Now, a quick word from our sponsors. Today's BackTable Podcast is sponsored by Boston Scientific's Urology Division. Boston Scientific is dedicated to transforming lives through innovative medical solutions that improve the health of patients around the world. These include treatments options for benign prostate hyperplasia, or BPH, one of the most prevalent urology conditions facing men today. Green light laser therapy offers a clinically proven alternative to traditional transurethral resection of the prostate. With comparable, durable outcomes, green light laser therapy can also provide additional potential benefits such as reduced bleeding and shorter hospitalization with an ability to treat various prostate anatomies. Green light laser therapy is an effective prostate treatment option that has been proven to have few complications, a low reintervention rate, and reduce lower urinary tract symptoms up to 15 years. This therapy is aimed to transform the way prostate treatment is approached and can deliver optimal outcomes and improving patients' overall quality of life. Now, back to the show. The Jose Silva is your host this week. Today we have Dr. Julie Riley. Dr. Riley is the Departmental Vice Chair, the Hall Black Reed Endowed Professor, and the Residency Program Director at University of Arkansas for Medical Sciences. Dr. Riley received her Doctor of Medicine with distinction in community service from St. Louis University School of Medicine. She completed her residency in urology at the University of Missouri-Columbia and continued her training with a fellowship in endourology, robotics, and laparoscopy at the University of Pittsburgh. She is on the editorial board of Urology Practice. Her clinical interests are surgical and medical management of nephrolithiasis, renal and uteral reconstruction, BPH, renal transplantation, and clinical practice efficiency and ease of practice. Julie, welcome to BackTable.
Well, thank you, Jose. Every time that I hear people go over all my stuff, I'm just like, oh gosh, so much to go over. We spend so much time in school, so thank you for that introduction.
No, it's awesome. I mean, today we're going to talk about ureteroscopy, but I want to dive into reconstruction or stuff as well, knowing that background. So Julie, like I mentioned, we're going to be talking about ureteroscopy and new uteroscopes and just a little bit of the science when you go into a renal pelvis ureter. So in terms of ureteroscopy, I mean, who is a candidate, who is not a candidate?
Yeah, so the nice thing about ureteroscopy is that just about anybody can have a ureteroscopy as long as they are a surgical candidate. So as long as we can have anesthesia clear them, you can probably put a ureteroscope where you need to go to take out the stone. A few caveats to that, of course, are that, lower pole stones, very large stones, are going to take significantly more time, significantly more, effect on the scopes, putting more pressure on them. But truthfully, just about any stone can be managed that way, and that is one of the very large appeals of ureteroscopy.
And in terms of possible complications of ureteroscopy, I mean, this is probably the procedure that I do the most. I see a lot of stones. And when the patients ask me of possible complications, I really just talk about after the procedure, the stent, and what they're going to feel out of the stent. But I really never, other than blood, infection for patients that might have a stone for a long time. But I really don't dive into more of the real complications or serious complications. So can you talk about a little of the complications when you are talking with a patient?
Yeah, I'm much like you that some of the biggest things I'm going to talk about is that stent discomfort and the need for the stent and what that's all about. I think really laying down the expectations for patients goes a really long way to help them get through that stent pain. But some of the more severe complications, I do talk about infections, and I will highlight that some of these patients can get quite sick, particularly these very large stones, patients that have complex anatomy. And these are a lot of the patients that I'm seeing that are referred to me. And so I do really highlight this infection risk and that is not a minuscule thing. The other thing I do talk about is the chance of either not being able to get the scope into the kidney, either, a tight ureter, something like that's a possibility. And then also strictures and scarring in the future, and that we do need to continue to monitor them afterwards. And I think the other thing that we really, I wish that we did better, and I try to do this as well, is to really talk about this is a long-term disease and that they're going to need follow-up after that ureteroscopy. So it's not even just the complication of the surgery, but this is a disease process that needs managed.
I'll definitely add that to what I tell the patient, because I never talk about disease or stone. I say, hey, they always ask, hey, I'm going to have another one in the future. Well, if you already had one, chances are that you may have one in the future. So in terms of, you mentioned the infection, what things can you do to minimize infections?
Yeah, I think the biggest thing is prevention. So making sure that you've actually worked up the patient beforehand. I get routinely a urine culture on all of my patients. I'm going to treat them with antibiotics if that is positive for at least 5 to 7 days beforehand. I give very strong antibiotics perioperatively to make sure that we avoid any of those infections. And if I see any signs of infection during the case, so if they're having purulence, maybe in the PACU that they're not exactly behaving as well as they should, I'm going to certainly have a low threshold to put those patients onto antibiotics for a period of time afterwards. The vast majority of my patients, however, they're getting a one-time dose perioperatively, because the vast majority of patients, that's truly what they need. But these patients that come in with infections already, they were already stented for their pyelonephritis, I'm going to be much more liberal with the use of antibiotics and making sure that I'm very directed based upon cultures.
And you mentioned those patients after they already came to the hospital, you put a stent up. Let's say if those patients, sometimes it happens that the urine culture, even though they have the symptoms, the urine culture is negative. Do you have any preference on antibiotic?
Yeah, I typically give ampicillin and gentamicin for my perioperative period. If I truly believe that they had an infection, but we missed the culture, right, because they got the dose of antibiotics in the ER before we ever even saw them, that's a very common scenario, then I'm usually going to give something like, sulfamethasol or some sort of cephalosporin beforehand if I truly believe that they have something that, is really at risk. And that's going to be how I manage them preoperatively. Postoperatively, I really try to get them off of their antibiotics as much as possible, because once they're stone-free, really most of those risks should be gone.
And for those patients, let's say pre-stented, do you think that there's a difference if the stone is in the kidney versus the ureter in terms of risk of infection or after the procedure?
I actually don't really notice that there's a big difference whether it's in the ureter or it's in the kidney in terms of the infection risk. I think if they needed a stent beforehand, that risk exists because we've instrumented the stent is in. In terms of the location of the stone, not as much. The size of the stone, I do think matters though. So if it's up in the kidney and it's a 2-3 centimeter stone, I'm going to be there a long time. I think they do have a much higher risk of getting an infection from that.
In those patients, that is a very big stone, 2 to 3 centimeters. What's your ideal scenario? Let's say if the patient goes to the office, no symptoms of infections. Are you trying to put an access sheath on these patients? What are you doing with these patients that have big stones?
Yeah, I use access sheaths very liberally. I like them. I also train residents, so I think that it's really very nice tool to have while you're training residents. It just a lot less chance of pulling scopes in and out and losing access. But these really large stones, I worry a lot about the pressures that are building up within the kidney. And I think that the access sheath allows the kidney to decompress a lot, not have as much of that pressure going on, and also just flushes some of the pieces out while I'm dusting. I think also we generate a lot of temperature issues with our high power lasers, so that sheath allows a lot more irrigation to go in with, again, these safer pressures. So I do believe that those sheaths are really making a big difference.
So you mentioned temperature, you mentioned intravenous pressure. How technology has helped to minimize complications when we're doing ureteroscopies?
Yeah, gosh, every one of these smaller scopes, every one of these high-power lasers, these are helping us to do more and more stones, giving less complications. But I think the big game changer that's come out that I'm really excited to start using and have had experience with is this new LithoVue Elite to be able to measure the pressures. And obviously, this is one product from Boston Scientific. I certainly think that all the other companies are going to jump on board, which I certainly recommend, or I highly am excited about the competition to see where, some of these prices can go. But the reality is right now we have the LithoVue Elite to measure these pressures with the scope. And that has been, I think, very interesting to see as I've used this, how much pressure we actually generate in a very quick fashion. I mean, if there's not a sheath in, it's amazing how fast the pressure goes up. If we irrigate too hard, it is for sure I can see that pressure go up. Even as we are lasering up against the wall or into a calyx or we're sitting in an infundibulum, definitely can see the pressure go up. I actually had a patient that had a narrowed UPJ that we were working on, and it required me to actually incise the UPJ to get the sheath in. But before we actually did that, I put the scope in to measure the pressures. There was no question that pressure was higher just sitting with that kidney alone. So I believe that this is going to be a big change for us, and that having real-time monitoring of these pressures is going to translate into better outcomes for patients. There's no question having more information is going to be good.
And in terms of intrarenal pressure, what are we talking about? What's normal? What's abnormal? Where we are in a dangerous zone? And the other question will be, what do you use to irrigate the kidney?
Yeah. So in terms of what is normal, so an intrarenal pressure should be sitting, the measurements have shown it's around 6 of just a resting kidney, no instrumentation. When we put instruments in, we can easily see that go up without a whole lot of, fluid, without a whole lot of manipulation. It's going to go up around 15, 20 millimeters of mercury. The danger zone is above 40, more or less, because that's where we start to see maybe some pilovenous backflow, and that might be where we're starting to get some of the infection risk. The problem that we have right now is, for how long? Is that like a one-time burst? Is that a big deal? Or is it over a long period of time? So, the question is, if you give one shot and it goes up to 100, but for, a half a second, quarter of a second, is that worse than if you maintained at 50 for 5 minutes? And none of us know the answer to that at this point. But there's no question, if we don't measure it, we'll never know the answer to that. I personally use a hand irrigation, so I do know that those certainly can generate a lot of pressure, but it gives me a lot of control with the instruments. And again, I'm training residents, so I'm usually with the hand pump, and I can manipulate the stones a little bit to help the residents be a little bit more successful with that and kind of keep some of that control of where the stone is. I don't think that is written in stone that you have to do hand irrigation versus pressure irrigation versus gravity. I think all of those things serve their purpose, and if you're successful at any one of those things, do that. But I personally use hand irrigation.
And Julie, in terms of putting an exercise, now that you're actually seeing intrarenal pressures, sometimes, let's say you have a 1 centimeter stone in the kidney, the ureter is very narrow, you don't want to take the patient again, and this is a patient that comes as outpatient, not infected, and you don't want to put a stent and then come back another week to do it. So you go to the kidney, there's not that much drainage, and those patients usually then complain of back pain. Hopefully they don't go into infection, but those are the patients that I see that are really having more pressure in the back in PACU. What do you usually do? Is that usually what you do, or you prefer just to put a stent and come back on another day you can put an access sheath?
Yeah, I think that there's a lot of discussion about this, and actually this was some discussion that we had at the recent AUA, but I think stenting and coming back is obviously the safest thing to do. And I think you have to take into account a lot of patient factors in that. You may not have that much time to bring the patient back into the operating room. They may have to wait quite a significant amount of time. So you may be more forced to push that a little bit more, particularly if you understand that the patient doesn't like stents, doesn't like the whole experience of stones, and you need to just get it done. I am not if it's a short, narrowed area, so less than 2 centimeters, I have no problem using a balloon to dilate up and then put the sheath in to allow access in that way to save an extra trip to the operating room. I think if it's a long, narrowed ureter, you are going to be kind of obligated to either put the flexible scope in, accept that you're going to have some higher pressures. This is a great time to make sure that you get in, get out, be very efficient with your lasering, and really don't spend a lot of extra time looking around, doing things like that. Be very efficient with that. But if all else fails, stent and come back, even if the patient is really unhappy, the reality is you did the safe thing and you're avoiding some of this. I think we're going to find as we're measuring these pressures, that does really correlate whenever we go in without a sheath, whenever we have very narrowed ureters. I think we're going to see that pressure goes up. Now, whether that translates into more pain, bad outcomes for the patient in terms of infection, I don't know yet, but it does seem like those at least correlate.
And Julie, in terms of, you mentioned the balloon, if you do dilate the ureter, does it mean the stent stays longer?
I would leave the stent for at least 2 weeks, but I would argue if I have a narrowed ureter, probably leaving a stent for 2 weeks anyway. So, they're not sure that I'm really trading a whole lot there. And I think all those patients require follow-up anyway. So I'm going to be getting ultrasounds. I'm going to be watching for those obstructions.
And in the time that you're monitoring those intrarenal pressures, have you been able to tell a correlation between infections at higher pressure versus not infection and lower pressures?
I would say that my data is just simply too small to really make that assessment just yet. I have certainly seen patients that have a little bit more pressures in their kidneys have had more pain. Now, what I have not been able to correlate yet is how long does that pain last for. I certainly have had that experience like you're talking about in the PACU. They're definitely having more pain. But in terms of actually correlating that to more patient phone calls, more need for pain medicines, things like that, trips to the ER, my data is just too much in its infancy to really say that. And I think everybody's data is sort of in that state right now. So more to come, and I'm very excited to see that. But I think without the real-time monitoring, we'll just never know.
And in terms of severe complications, other than infection, with increased renal pressure, are we talking about fornix rupture, permanent damage to the kidney? What are we really talking about?
Yeah, I think some of the other very severe complications are going to be ureter injuries. In terms of fornicale ruptures, we know that whenever stones are there and there's a fornicale rupture, we don't have long-term damage. So I can't really believe that that's going to be true in ureteroscopy either. I think fornicale ruptures, that's going to lead to infections and more issues there. But long-term, I'm not sure I can say that. But I would say, ureter injuries, is there a way that, by measuring some of the pressures that we know whenever we're putting a lot of force onto a ureter? I don't know. I think more to come on that too. But I think those are some of the severe complications that we see. And we've all seen the patient who's had ureteroscopy and comes back later on with a stricture. Is that somebody else's ureteroscopy? I always make the joke that that wasn't mine, that was somebody else's. But I'm pretty confident, knowing how many ureteroscopies I've done and the complication rate of stricture, it's happened. And is there a way that we can use pressure monitoring to know how much force we're putting on for sheaths and how much force we're really putting onto the walls of the ureter? We don't have that technology yet, but I certainly think that is a huge place where we could really see what's happening in the ureter, because those are very dreaded complications.
Yeah, and we always, residency, I remember, because right now I'm alone in the hospital, but when I was in residency, there's multiple residents with me, different stages in their years. But essentially, everybody puts a little bit more pressure, or the resistance of the ureter to everybody was very subjective. So for some, it was okay to push a little bit more. For some, it was, if it didn't go out just very passively, they wouldn't put it. So that information that you're saying, just having that information, that actual live pressure, how much you're putting into the ureter will be very significant, because right now we don't know.
And there are definitely studies saying, we don't really have an actual force, like this is too much, this is too little. Everyone's ureter is a little bit different. But really interesting studies coming out very recently about ureters change with age. And we know that the distal ureter is different from the proximal ureter, and we lose some of those differences as we age. And
I think for me, I definitely find that the young guys tend to have very tight ureters, and I really struggle with them. And very unfortunately, they have to have stents longer, and they do the worst with stents, right? And we've all seen kind of that little old lady, ureters wide open, you put a stent in, they never even feel it. And I do think that we're going to find that everyone's ureters are a little bit different. We treat them all the same, right? I mean, we've all learned and we all do it pretty much the same, but I think we're going to find that, not everybody's ureter is the same, and we do have to treat them very differently.
And for me, I find it challenging in the sense that, for example, patients, younger guys that they don't have insurance, they come to the hospital, you want to try to do it in one shot, and maybe you force a little bit more, so that means that the stent stays longer. So it's always a balance between that and like you said, I mean, always the safest way is just putting a stent and coming back another day.
Yeah, it's true. And it is hard because we have so many patients with so many social issues, and we don't know how to do that either, right? I mean, it's hard whenever it's the middle of the night, you get called in, you're like, I'm just trying to do my job here. And the patient throws at you a lot of things that are really important. But how do you prioritize all those things? And I don't know. I don't have a good answer either, but I do know that the longer I go in my career, the more I realize all these patients are really different, and there's some really hard problems for us to try to solve. So I'm hoping your younger generation, I hope you figure out how to make the healthcare system better.
So I haven't used the LithoVue Elite. I have used the first generation. I mean, you have the separate monitor just as the old one, but you also have, is it attached to the same monitor, or is it a separate piece that you get the reading from the intrarenal pressure, or how is it? Because I haven't seen it.
Yeah, it's a separate box and a separate monitor. So it is a little bit, I will say that the vision on it, I think, is a little bit better than the original LithoVue. It has a pretty big monitor. It's a little bit bigger than kind of the original LithoVue monitor, but off to the side, it has a pressure monitor on it, and you can see it real time. You can make some settings on it where it'll change colors if you're going high. I think there might even be a bell on it. I'm not sure. I turn off all the sound on it because I don't really want to hear that, but I think they told me that. But whenever you start, you pull the scope out, and you have to actually calibrate it. So you have to set it in water and kind of swirl it around once you plug it in, and it really walks you through that, but it takes about 5 or 10 seconds to do that. But really similar, they do have a couple of different buttons on the front that allow you to do a little bit easier recording and taking pictures, and some personalized settings on that they've updated. But all in all, it handles very similar. I didn't really notice a big difference between them. I think between all of the disposable scopes, I think all of them handle pretty well. I always make the joke they kind of feel a little Fisher Price, right? Like they feel very cheap and plasticky. The LithoVue Elite does feel a little bit more substantial in your hand than the original one, but I still think they all kind of feel a little more plasticky than kind of your reusable scope, where you really feel that bulk in your hand that feels very steady.
So, I mean, the LithoVue, the vision while you're breaking a stone is very good, because with some of the reusable scopes, they might look great when you're just doing a nephroscopy, but when you start actually breaking stones and putting it to work, then maybe you don't get that great image that as you do with the LithoVue.
Yeah, I mean, I think also with some of the disposables that far away, like there's kind of that, oh gosh, there's like a halo almost, like it's kind of black in the background, right? There's a little bit of the abyss look behind you. But I do think it focuses pretty well in really what you're looking at. I still think that some of the times whenever you're using the laser, you get a little bit of feedback on those disposable ones that you don't get in the reusable ones. But I really like having the disposables, particularly for these really large stones, because I've definitely put those scopes in places in the kidney that I would never put a reusable scope, because I would break it. I'd be too afraid I'd break it. And so far I have not broken one of the disposable scopes in the patient. So fingers crossed that does not happen in my next cases. But the reality is it really has added a lot to be able to get scopes where they really haven't been able to go before.
Yeah, and now the hospital is getting reimbursed depending on the insurance, but they are getting reimbursed for these disposable scopes. So that's, I have been more liberal, or the hospital have been letting me use more the disposables. So Julie, in terms of when you're there in the kidney and the ureteroscopy that you do, Has it changed now that you are monitoring the intrarenal pressure versus before?
I am definitely a lot more cautious as I'm using my hand irrigation. I'm paying a lot more attention whenever I take the scope and my resident is using the hand irrigation or an assistant is using it as to what they're doing. And so I can really be paying a lot of attention just watching the screen, knowing what they're doing too. I'm definitely very aware that a sheath is a really good thing. When I haven't used a sheath with it, I've been pretty nervous as that pressure is going up. And I'm pretty careful to sort of take a break, give the kidney a little bit of a break if I'm noticing that the pressure is going up, and just allow some of that fluid to drain out, maybe even pushing my sheath a little bit higher. But a lot more of it is I'm just being a lot more cautious than I really have been before. Not to say that I'm, going crazy doing ureteroscopies or anything, but the reality is I'm definitely seeing it, and I'm kind of slowing down, making sure that I keep that pressure a little bit lower. It's not adding a whole lot of time to do it. I mean, I'm not seeing, huge differences in time. My staff is not complaining about that, but I definitely am not necessarily just putting my foot on the pedal and going for, going pretty straight through that. I'm really kind of adjusting and making those modifications as I go.
And you mentioned that you try to put the sheath a little bit higher. And I mean, if you're in a upper pole stone, upper pole calyx, it's much easier. But sometimes when you go into the lower pole, that high access sheath will prevent that ureteroscope going down into that calyx. Are you trying to move the patient, move the stone to another position to be able to put the access sheath, or that really is not that important?
Yeah. I am not really somebody that moves stones around very often. I usually do a lot of my lithotripsy in situ. I think moving it is fine. I just find that if I can actually get a basket around the stone and move it someplace, I'm usually like, well, it's probably time to just pull it out. So I don't tend to do that. What I will sometimes do in the lower pole is I'll get my scope down there. And again, these disposable scopes are great because you can flex up against that sheath much more than you would with your reusable scope, and use a lot more passive deflection against, to get down in the lower pole. But if I really can't keep my sheath up, I may laser for a little bit, and then I might go ahead, take my scope out, push my sheath up, irrigate some with, I'll use a 5 French Pollock. Now we're seeing more devices to actually do some irrigation and suction, which I think is the next thing that's going to really revolutionize ureteroscopy. But I just use, a Pollock catheter and irrigate things out. And then I'll put my scope back in, pull the sheath back. Yes, it's a little bit inconvenient to do that, but I can get a lot of that dust to irrigate out and see a lot better. And it also gives just a second to let the kidney kind of relax, drain out, cool the temperatures off if I'm really using pretty high power settings. Also, frankly, gives my hands a little bit of a break, gives my residents a little bit of a break, right? These cases can be very long, very frustrating. And as you start getting frustrated in ureteroscopy, you start, getting a little bit more fidgety, a little bit more clumsy with it. And I think sometimes you just have to give yourself a little bit of a break, do something a little bit different to kind of keep yourself engaged in the whole procedure.
So, I mean, before you were able to monitor the intrarenal pressure, is there a way to eyeball it for somebody that doesn't have access to a LithoVue Elite?
I thought that the answer to that would be yes, and I was sort of hoping that would be true. But watching it, I am truly amazed at sometimes whenever that pressure jumps up and you're like, how did that even happen? It looks fine. And sometimes, whenever you're up there and it's getting really distended, yeah, the pressure's up high. But I was actually sort of surprised sometimes whenever it was pretty hydronephrotic, pressures sometimes weren't really going up as I thought they would. So it's not as intuitive as I would have liked it to be and as I would have hoped that I could have predict. I wish I would have been a better surgeon at that one. But unfortunately, I think it really proves we have to monitor it.
And are you using it? Or you mentioned that you sometimes use the other ones, but if you're using it for a small stone, will you think the actually monitoring the intrarenal pressure is important, or is more for when you're going to be there a little bit longer?
Yeah, I selectively use this. My institution for sure does not want me to use this on every case. It is significantly more expensive, and I get it, and we need to be fiscally responsible. We can't pass these charges off to patients and to our hospitals. I'm typically choosing them for large stones, patients that have some sort of immunocompromised state. I operate on transplant patients, so those are really high targeted patients. People that I know are at risk for having an infection, so spina bifida patients, people who have already proven that they get septic from their procedures. I certainly think that those are the patients I'm going to be using that for. But if it's a small stone, I'm not going to be putting a lot of stress on my scopes. I'm going to use my reusable scope because that's exactly, that place in the process of how to do that. But if, it's somebody that I really need to see that pressure, it's a big deal if they get an infection, then yes, I'm going to pull that out. I'm going to use the extra money to prevent. Hopefully this will show up that we're preventing the infection and the admission and all the downstream effects of that.
And in terms of preventing stone, specifically when you're preventing infection, when you're there, do you know in terms of time, is it going to be the constant high pressure that might lead you to infections? Or, just trying to compare for the person that doesn't have access to the LithoVue Elite, what they can do for that same patient if they're not able to monitor the torino pressure.
I think, if you can't get the technology, I really think access sheaths are a good thing. Don't be afraid to use those access sheaths. Yes, you might have to put a stent in. Yes, patients aren't going to like that. But I think if you explain to patients up front, this is why I'm doing this, is to try to prevent some of these infections, some of this high pressure systems, and, really some of the pain that might come. Again, laying down the expectations is really going to be the biggest thing to do that. So I would say if you don't have access to that, be very careful about your irrigation. Don't set your gravity too high. If you're using a hand pump, make sure that the person who's using that hand pump really understands what they're doing. I would be pretty hesitant to give it to a really inexperienced, scrub tech. If it's somebody you work with all the time, great. They know what's going on and you can really help them through that. But somebody that really doesn't know, you're going to generate a lot of high pressure. So I would be very cognizant about that. So, if you can't get it, that would be my suggestions.
Yeah, sometimes I see, like you mentioned, techs that are not familiar with just pushing the water in, that they push it like there's no tomorrow, like they're going to blow it up. I say, hey, take it easy.
Right. And I usually just kind of grab a hold and I'm like, it's just this teeny little pump and I can see everything. That's all I really need. But I'm always surprised that sometimes I kind of turn my head and I realize all of a sudden somebody's pushing pretty hard on that hand pump. So I think, I have a luxury of having very qualified residents who are holding the scope and I'm holding the hand pump. So we have two very qualified people to do that. I think if you're at an institution where maybe you don't have a specialized team, it's going to be a lot harder. So you might think about switching to gravity or very low pressure bags to be able to have more control over that and make sure that it's a little bit more steady.
And Julie, you mentioned it briefly, but what's the future like for ureteroscopy?
Gosh, I think we're going to continue to see ureteroscopy grow and grow and grow because we're going to see it's more effective than shockwave and it's less invasive than percutaneous procedures. Even as we miniaturize PCNLs, I still think patients are going to see a huge value in this outpatient procedure that doesn't require any incisions. The suction irrigators are going to really do it. I am hoping and praying that they get us cordless ureteroscopes, right? Wouldn't that be amazing that we don't have to plug in a ureteroscope? And obviously our vision is just going to get better and better. And, it would be nice, some of these robotic techniques kind of saving our hands. We got to get it a lot cheaper, but I think those will be a lot more precise and really allow the surgeons to be able to save their hands and their wrists. I know all of us who do ureteroscopies, we all know that we're tired at the end of the day. Our legs hurt, our shoulders hurt, our hands hurt. And having that robotic technology, I think, is going to make a big difference. Some of the stuff about moving stones around with, the ultrasound guidance, I think that could be a really interesting thing. It hasn't really taken off as much as I would have thought it has at this point, but I think as the technology grows, we're going to see a big difference in that. So I think that's sort of the future, is we're going to have a lot more ureteroscopy. And as residents coming out of training have done more and more and more, we're going to see that they are just
really phenomenal at the techniques. And I hope that they are better than I am, so that way they can move this technology forward.
So you mentioned the ergonomics. So I've been, I would say, for the past 6 months, I've been sitting down for my ureteroscopies. And yeah, I like it. I like it. I mean, I still stand up sometimes. For those big stones, I just sit down, stand up, and just keep moving. But yeah, my hand hurt. I cannot trust the tech to hold the ureteroscope for a while. So yeah, but hopefully if we get things that make it easy faster or break stone faster, like the suction, the vacuum, and all that will make it easier for us to do big stones. And Julie, in your practice, you've been doing less PCNLs compared to before?
Absolutely, which is sad because I really do like PCNLs, but I appreciate that patients aren't really as interested in doing those PCNLs, and definitely seeing a lot more interest in ureteroscopy. So I want to do more PCNLs, but fair enough, that's not what the patients want.
Because sometimes, I mean, for those big stones, I mean, if it's a single 3 centimeter stone in the renal pelvis, you can do a PCNL in 30 minutes, 45 minutes versus 2 or 3 hours.
You're right. And I still am telling my patients that I think one of the things that has really changed, and one of the things I see in my practice is there is a huge use of blood thinners, right? I don't know about you, but I have definitely seen that there is more and more and more, and patients have to be on these. It's harder and harder to get them off of them. And ureteroscopy, I do them on blood thinners. So I don't need to stop that. Whereas in a PCNL or shockwave, I need to stop those. And so I think that that's another big thing. It's a little less stressful than doing a PCNL. There's a lot more fluid shifts in PCNLs. There's a lot more to consider in PCNLs in terms of risks and, lung injury, bleeding risk. Yeah, those are small, but they're very unique to that procedure. And I'm seeing a lot more sick patients walk in my door that their lungs are not that good. They really can't handle, the risk of bleeding. And so that pushes me more into ureteroscopy. And so I'm pushing the limits of what it can do, because sometimes my patients are sort of pushing what I have to do to get that stone out. It never ceases to amaze me whenever you're like, oh gosh, I didn't really realize that somebody as frail as you could manage to get a stone that just has to get treated because it's obstructing and it's getting you sick. And it's just amazing how many more sick patients are coming in like that.
And in those patients with blood thinners, do you try to take the stent sooner rather than later, or you treat them the same?
I treat them the same, and I have not noticed any difference with that. They certainly do have a little bit more bleeding risk, but really nothing that's been significant change in terms of the way that, their management afterwards or needing to come in more or something like that. So I treat them the same.
Yeah, I had an issue once with a patient, but he had prostate cancer and he had a severe radiation cystitis on blood thinners, and it was a mess. I mean, eventually, after a week, it was everything good, but that week was stressful for me and for the patient.
And it's true, right? There's that patient that you're like, I had no idea that you could possibly need to get this ureteroscopy. Oh, awesome. I'm so excited I get to do it.
Exactly. And he had another urologist, but he ended up in my hospital.
Sure.
But anyway. So, Julie, I mean, anything else you want to add? I think we covered a lot, very meaningful things that you mentioned in terms of the knowledge of that intravenous pressure and ureteroscopy and all. Anything else you want to add?
No, I think that we covered a lot in this, Jose. I think this was really good.
Yeah. So, Julie, thank you for being on the show. I really enjoy this conversation, and hopefully we'll talk again soon.
Yeah, I appreciate it.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz, with support from
Devontae Delbrun.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.
The content in this podcast is the opinion of Dr. Julie Riley and does not represent the opinion of Boston Scientific.